it's a it's a good feeling that you have a new skill in your armamentarium to become a good doctor. So I'd like to give kudos or acknowledge our judges who toiled to read your researches. Previously, I was one of those judges. Sabi ni kita, Doc, ito na yung mga case reports nyo. Oh no, bibigyan ako 10 case report na babasahin nyo. So I know how hard you guys toiled over these researches, but you have to keep doing it. So for our original research paper presentation, we have to give thanks to Dr. Harold Michael Gomez, Gideon Cabales, and Annette Raso. Thank you guys. And for the case report presentation, we have Dr. Japit Galagaran, Ana Cristina Gutierrez Rubio, and Julissa De Jesus Venluan. Thank you. For the original research poster presentation, ginawa niyo poster, may silbi rin yan. We have to thank Dr. Kathleen Keslani, Cassandra Camille Machuca. And for the case report paper presentation, Aisel Fernandez and Melissa Aquino Villamin. Thank you guys. So, like what we have said, we had a total of 11 original papers and 52 case reports. So here are now the 10 finalists. For original research, first paper is Prognostic Factors for Disease Progression and Mortality of Childhood Onset Lupus Nephritis, an 8-year retrospective cohort study in a tertiary hospital in the Philippines, made by Dr. Marie Ases, Dr. Checa T, Lourdes Paula Resontok from PGH. The second paper, Hyperuricemia as an Indicator for Lupus Nephritis, a systematic review and meta-analysis. By Dr. Ray John Villanueva, RJ Villanueva, from Western Visayas. Third paper, Prognostic Value of Erythrocyte Sedimentation Rate to C-reactive protein ratio in distinguishing infection from the flare in pediatric patients and SLE presenting with fever. By Dr. Noreen Ruda Shenida Kamomot from Vicente Soto Memorial Medical Center. The next paper is the prevalence of musculoskeletal disorders among Filipino patients with diabetes in a tertiary hospital, a cross-sectional study by Dr. Carl Tagumata, Therese Landok Natividad from East Ave, markers, vitamin D3 levels, and clinical characteristics with disease activity among Filipinos with HL spondylitis seen in a tertiary center by Dr. Noreen Garcia and Ports. First paper is a case of sacroiliitis in a young Filipino male with concomitant HIV and syphilis, made by Dr. Melbert Parcon, Hazel Agapao, Annalyn Humeras, Helmar Saldivilla from West Visayas State University. Next paper is pseudo-pseudomate syndrome or Chalma syndrome, as initial presentation in a young female with SLE by Dr. Chad Fernandez and Jad Elmer Quesilidillo from Davao Regional Medical Center. Next paper is ankylosing spondylitis complicated by acquired immunodeficiency syndrome, pancreatic tuberculosis, cryptococcal meningitis, and immunoglobulin A nephropathy in a young Filipino male. A case of Intan, Rika King, Melissa Aquino, Villamin from SLMC. And next paper is hemophagocytic lymphohistiocytosis presenting as B symptoms in a young female with SLE in remission. Case report again by Dr. Elaine Tan and Dr. Eileen Abanlog de Matulak from SLMC. And last paper is diffuse alveolar hemorrhage in lupus, a rare febrile outcome in a therapeutic plasma exchange plus rituximab. Case series, wow. By L'Oreal Barsanga, Joy Bukat, Gail Monique Yao Tandok, Karen Cortez, and Aleli Pamplona from Baguio General and Medical Center. So guys, we'll be presenting a pre-recorded presentation. If you have any questions, I'm sorry, due to time constraints, just write down your questions and you could forward it to me or any of the presenters who made the paper. So if you have, if there's no other things, case prognostic factors for disease progression.
Lupus nephritis is a significant cause of morbidity and mortality in pediatric patients with systemic lupus erythematosus or SLE. Data obtained from 2010 to 2013 show that overall survival of our patients was lower compared to worldwide data. An updated and more comprehensive study to determine factors that impact disease outcomes in our patients, taking into consideration newly adopted treatment regimens, can help in the improvement of healthcare delivery for lupus nephritis patients in our setting, as well as other low-income settings. We conducted this study to describe the clinical characteristics, identify prognostic factors, and determine the treatment outcomes of childhood onset lupus nephritis or CLN at our institution. This retrospective study included all patients younger than 19 years old with LN, diagnosed from January 2014 to December 2021 in our center. A total of 128 patients who satisfied the inclusion criteria were identified. Descriptive data were summarized using descriptive statistics. Overall survival was estimated using the Kaplan-Meier method. Independent predictors for mortality and CKD5 were determined using regression analysis. The mean age at diagnosis was 14.4 years, with a female to male ratio of 13.2:1. 88% presented with LN at the onset of SLE. The mean duration between onset of LN and diagnosis of LN was 2.1 months. Nephrotic syndrome was the most common clinical syndrome. Proteinuria, anemia, and a positive ANA were the most common laboratory findings. Only 16% underwent kidney biopsy. The most common histopathologic class was class 3. Majority received a combination of oral and IV steroids for induction therapy. About an equal number of patients received IV cyclophosphamide.
Ayusin ko lang yung sa akin.
Constrained. While 3 patients initially started on IV cyclophosphamide were shifted to MMF, 2 due to resistance and 1 due to fear of infertility. The most common maintenance therapies used were MMF and IV cyclophosphamide, given for a mean duration of 1.8 years at follow-up. Majority received hydroxychloroquine and enalapril as adjunctive therapy. 60% had a delay in therapy, and 38% were poorly compliant to treatment. The most common treatment-associated adverse events were Cushingoid fasces, invasive infection, and hospitalization. A significantly higher proportion of patients treated with glucocorticoids and IV cyclophosphamide experienced infection and hospitalization compared to those treated with glucocorticoids and MMF as induction therapy. There was no significant difference in outcomes between the two groups. 25 patients died during the observation period. Infection was the most common cause of death. Overall survival at 1 and 8 years were 82.71% and 55.87% respectively. Nephrotic range proteinuria at diagnosis of LN and failure to achieve remission at 6 months increased hazards for mortality, while remission at 3 months decreased hazards for mortality. Hypertension at diagnosis and failure to achieve remission at 6 months increased the odds of developing CKD5. Our studies show that demographic, clinical, and lab characteristics of our patients are comparable to earlier local and worldwide data. Almost half of our patients had a delay in diagnosis. This was mostly because of misdiagnosis as urinary tract infection, which is not surprising, with fever, hematuria, and pyuria being among the most. Biopsy was not done in a vast majority of our patients, and most were treated based on renal manifestations, foremost the degree of proteinuria. Given that the correlation between clinical manifestations and histopathologic class has not been clearly defined for CLN, the inability to perform kidney biopsy may have affected treatment outcomes in our cohort of patients. Adherence to treatment is a cause of concern. Lack of available bed for elective admission and administration of IV medications, transportation issues, and financial constraints all contributed to poor adherence. Glucocorticoid toxicity is common in our setting as in other settings. Cosmetic complications predominate in our patients, and severe organ damage and systemic complications were uncommon. Although infection is common, this cannot be attributed to glucocorticoids alone in patients with CLN. With their differences being uncertain, we compared treatment-associated adverse events and outcomes between MMF and IV cyclophosphamide use during induction therapy. In our study, amenorrhea was not significantly different between the two drugs. Infection was significantly higher in the IV cyclophosphamide group, and the addition of MMF does not appear to have improved overall survival. Prognostic factors for mortality and progression to CKD5 identified in this cohort are similar to worldwide data. Our findings reinforce the importance of achieving early remission in the outcomes of CLN patients. Overall survival is even lower in this era compared to earlier data. These may be due to underaddressed issues of suboptimal diagnostic and therapeutic management and perceived decline in follow-up and elective admissions in the last 2 years due to the COVID-19 pandemic. Overall survival remains low in our setting. Resource issues affect optimal diagnostic and therapeutic management. Failure to achieve early remission is an important predictor of mortality and CKD5. To address the limitations of the research design and the sample size of this study, prospective and larger studies are recommended. Thank you for your kind attention.
Good morning. This is RJ Villanueva, together with my co-authors Dr. Porras, Dr. Altura, and Dr. Favela of Western Visayas Medical Center, and I will be presenting a systematic review and meta-analysis entitled Hyperuricemia as an indicator for lupus nephritis. Lupus nephritis is usually the most serious manifestation of SLE and asymptomatic in most lupus patients. However, it is the leading causes of mortality in the first decade of disease along with infection. Uric acid has been recognized as a potential marker of endothelial dysfunction and kidney disease, hypertension, and other metabolic syndrome. This leads us to the objective of the study, which is to determine if hyperuricemia is an indicator for lupus nephritis. We conducted a systematic review and meta-analysis in accordance to the preferred reporting items for systematic reviews and meta-analysis. 1,786 studies has been identified through database search engines including PubMed, Cochrane, Herdin, Google Scholar, ScienceDirect, and MDPI. On initial screening, 1,774 were excluded, majority due to duplication. Studies including case reports, case series, case reviews, and studies which included SLE and hyperuricemia but no direct correlation with each other were also excluded. 12 records remained thereafter. 3 records were excluded on the next screening because they are all literature review. 4 other articles were excluded due to different primary outcomes, which lead us to the 5 remaining studies to be analyzed. This meta-analysis included cohort and cross-sectional studies. Inclusion criteria also included population of adult patients with SLE with or without nephritis. Exclusion criteria included review articles, abstracts, letters, and editorials, case reports, case series, and all in vitro animal studies. After several screening, studies included 2 cohorts and 3 cross-sectional studies. Quality of the included studies was assessed using Newcastle-Ottawa scale for risk of bias. Every study was evaluated based on selection, comparability, and outcome biases. Quality risk assessment of the 3 cross-sectional studies was shown in the screen, were assessed revealing good to very good quality studies. The 2 remaining studies revealed fair to good quality studies. This study included a total of 903 adult patients diagnosed with SLE with or without nephritis. All 5 studies had similar population, same primary outcome, and result which concluded that hyperuricemia can be an indicator for lupus nephritis, which lead us to the primary outcome of interest of this study, which is hyperuricemia as an indicator for lupus nephritis. All 5 studies were analyzed using Revman version 5.4.1, analyzing forest plot presented. It showed a significant mean difference favoring hyperuricemia in positive lupus nephritis with a mean difference of 1.92 within a 95% confidence interval with a heterogeneity of 86%. Due to high heterogeneity, subgroup analysis was done. A study of O et al. 2020 was excluded because it has the highest risk of bias based on Newcastle-Ottawa scale. The study of Young et al. 2010 was also excluded because mean and standard deviation were derived from the data using a different tool. After the studies were excluded, there was still a significant difference favoring hyperuricemia as an indicator for lupus nephritis, with a mean difference of 1.42 milligrams per deciliter within a 95% confidence interval with a decreased heterogeneity at 27%. This study found out that there is a significant difference in hyperuricemia as an indicator for lupus nephritis, favoring lupus nephritis group. A journal review of Dos Santos et al. 2020 stated that scientific evidence indicate that hyperuricemia may be a potential adjuvant in the development and progression of kidney manifestation in SLE, since high serum uric acid concentration may have been shown to be independently associated with kidney damage in lupus. They hypothesized that high serum uric acid concentration may be associated with kidney injury in SLE because uric acid at high concentration may promote activation of inflammatory pathways and formation and deposition of autoantibodies in the kidney. This in turn may lead to the reduction of GFR and consequently lower excretion of uric acid, which may aggravate kidney injury in SLE. Based on this study, hyperuricemia can be an indicator for lupus nephritis. However, evidence remains limited and more studies are needed in order to truly determine its effectiveness. We, the authors, recommend more studies, preferably randomized controlled trials, to truly determine if hyperuricemia can lead to the onset or progression to lupus nephritis, and to minimize or eliminate heterogeneity. Thank you.
Good morning, everyone. I am Dr. Noreen Joyce Rauda, and together with my co-author, Dr. Shanida Alcamumot, I am here to present our study entitled The Diagnostic Value of the ESR to CRP Ratio in distinguishing infection from flare in pediatric patients with SLE presenting with fever admitted at a tertiary hospital in Cebu City from January 1, 2016 to December 31, 2020. With infection still a leading cause of mortality among patients with SLE, even with the advances in critical care and in the advent of broad-spectrum antibiotics, research on biomarkers that allow early diagnosis and aggressive treatment in patients with suspected infection has been encouraged. CRP and ESR are nonspecific markers of systemic inflammation. An increase in both CRP and ESR can be observed in inflammation due to infection, autoimmune diseases, or malignancy. In 2018, a study was done on adult patients with SLE and found that each unit increase in the ratio of ESR to CRP was associated with a 17% increase in favor of fever being attributed to SLE flare compared to infection. Currently, no similar study has been published in the pediatric population. Thus, this study was conducted with the general objective of determining the diagnostic value of ESR to CRP ratio in distinguishing infection from disease flare among febrile pediatric SLE patients admitted at a tertiary hospital in Cebu City from 2016 to 2020. With the specific objectives of determining the prevalence of pediatric SLE, their demographic profile and clinical characteristics, the proportion of febrile patients with SLE who are active non-infected, active infected, inactive infected, their ESR, CRP, and ESR to CRP ratio. To compare the trend of ESR to CRP ratio of SLE active non-infected, SLE active infected, and SLE inactive infected patients according to the disease activity score and according to the severity of infection if present, and to determine the cutoff value of ESR to CRP ratio to distinguish SLE disease flare versus infection. This study utilized a cross-sectional study design conducted at the Tertiary Training Government Hospital in Cebu City. A total enumerative sampling was utilized in this study with the following inclusion and exclusion criteria. A study by Gulay and Dance in the Philippines from 2004 to 2008 found that the mean age at diagnosis was 14 years old with a range of 8 to 18 years old. In our study, the youngest SLE patient was age 7 years old, while the oldest patient was age 18 years old with a mean age of 15.6 in years during disease presentation. The majority of these patients were females, with the most common chief complaints of edema, fever, and dyspnea. The mean temperature upon admission is 37.9 degrees Celsius, with most patients presenting with very high disease activity upon admission. The majority of these patients were not subjected to immunotherapy. In terms of the patient's disposition, a third of the patients succumbed to death. Infection, SLE nephritis, and CNS lupus caused a significant deal in the morbidity and mortality in SLE. 52% or 40 of our patients were admitted for SLE flare with concomitant infections, while 48% or 37 were admitted for SLE flare alone. 20 patients who presented with infection were graded as severe infection, 15 had moderate, and 5 had mild infection. The most common causes of infection were pneumonia, urinary tract infection, and bacteremia. In a similar retrospective study by Little John et al. Of adult lupus patients presenting with fever, the ESR to CRP ratio was shown to be of value in differentiating between the infection and lupus flare, with ratios of more than 15 with the etiology of fever attributed to SLE flare and ratios of less than 2 correlated with infectious etiology. Our study supports these findings in the pediatric population of SLE. This study demonstrated a higher ESR to CRP ratio in patients with active SLE but without infection, recording a median value of 13.75 as compared to the active SLE with infection at 1.47. Using the binary logistic regression, the model recorded a p-value of 0.030. The beta coefficient of the logistic relationship between the ESR to CRP ratio was 0.063, which was less than 1. This is indicative that as the ESR to CRP ratio increases, the odds of having SLE active infected status decreases. And as the ESR to CRP ratio increases, the likelihood of having SLE active non-infected status becomes significantly more prominent. ESR to CRP ratio was relatively higher in patients who recorded with SLE in flare non-infected in all levels of disease activity. Using the area criteria for the ROC, the ESR to CRP ratio recorded a total diagnostic value of 85.6% to predict as SLE active non-infected patients, with a sensitivity of 81.1% and specificity of 80%. The cutoff value for the ESR to CRP ratio to diagnose SLE in flare non-infected is 5.61. In conclusion, we report a prevalence rate of 0.74 per 100,000 pediatric SLE patients during the given time frame, with a female-to-male ratio of 3.2:1 in pediatric patients, with most cases occurring in the adolescent years. There is a relatively higher ESR to CRP ratio among the SLE active non-infected group in all levels of disease activity. The total diagnostic value of the ESR to CRP ratio was 85.6% to predict SLE active non-infected patients. The cutoff value for the ESR to CRP ratio to diagnose SLE active non-infected is 5.61. Our study recommends considering the cutoff value of ESR to CRP ratio of 5.6 in pediatric SLE patients in flare but without infection, with lower values indicating presence of concomitant infection in a patient presenting with SLE flare. Further study of the utility of the ESR to CRP ratio in other autoimmune or rheumatic diseases is also recommended. Prospective studies are warranted to investigate further and validate the prognostic value of the ESR to CRP ratio and refine ratio cutoff points. Thank you.
Good day, doctors. I am presenting my study on the prevalence of musculoskeletal disorders among Filipino patients with diabetes in a tertiary hospital. The prevalence estimates of diabetes from the International Diabetes Federation in 2020 is about 6% among adult Filipinos. Among these diabetics, musculoskeletal symptoms may be a common complaint because of muscle loss and atrophy, especially among older individuals. Carvalho E. Silva et al. Explained that the association between musculoskeletal pain and diabetes can be explained by shared risk factors such as sedentarism and obesity. In the meta-analysis of Kaka et al., the pooled prevalence of musculoskeletal disorders among adults with diabetes mellitus was as high as 58%. Locally, a study of musculoskeletal symptoms in diabetic patients may improve the management of diabetes among Filipinos. The study aims to determine the prevalence of musculoskeletal disorders among Filipino patients with diabetes mellitus. Specifically, it aims to identify the prevalence of musculoskeletal disorders and the demographic profile of diabetic patients, to determine the association of glycemic control and body mass index with musculoskeletal disorders, and to enumerate the interaction of hypoglycemic agents, pain relievers, and concomitant medications that may have musculoskeletal adverse effects among these patients. Carvalho E. Silva et al. Documented that type 2 diabetes is associated with knee, hip, and neck or shoulder pain. They noted that the association was stronger among people with chronic pain and with neck or shoulder pain. Type 2 diabetes was reported as an independent risk factor for neck or shoulder pain only, but not for the other regions. Cagliero et al. Studied hand and shoulder abnormalities and showed no association between hemoglobin A1C and these disorders. The mean HbA1c was observed to be higher among patients with hand or shoulder syndromes compared to patients without them. Although there is no significant difference, the authors concluded that the HbA1c level is a determinant of the presence or absence of musculoskeletal complications. LOSA systematically analyzed the safety of combining NSAIDs and hypoglycemia-inducing drugs and concluded that the combination did not show evidence of changes in glycemic control, renal function, or adverse effects. A review by Kalitsuglau et al. On the effects of antidiabetic medications on the musculoskeletal health showed that these drugs may have varying outcomes in clinical studies. So this is a cross-sectional study that was conducted at the East Avenue Medical Center for 1 year, from May 2021 to April 2022. Participants were included based on the following criteria with sampling by total enumeration. And this is a sample questionnaire used in the study. The study included a total of 95 diabetic patients with a mean age of approximately 55 years old, of which more than half are males. About 37% of patients are smokers, about 45% are alcoholic beverages drinkers, and approximately 25% of these patients claim to have regular exercises. Majority of the respondents are employed in office or in manual labor. The most common comorbidity is hypertension at 44%, followed by neuroischemic foot ulcer and history of tuberculosis. The prevalence of musculoskeletal disorders is at 38.9%. This is slightly higher than what was reported by Majad et al. At 34% among Moroccan patients with type 1 and type 2 diabetes, but this is lower than the pooled prevalence of 58% in the meta-analysis of Kaka et al. As mentioned. Musculoskeletal pain most frequently involve the knee, and this is followed by the foot, with the hip being the least frequently involved. This is similar to the findings of Matthew et al., with the knee as the most commonly involved site at 33%, and with that of Carvalho e Silva et al. Demonstrating hip as the least frequently involved region at 11%. Now, relative to the total number of patients with MSK complaints, 48.6% had recent pain or pain less than 1 month, while 51.4% had chronic pain or more than 3 months. At almost 98%, type 2 diabetes is much more common than type 1, with a mean duration of 8.9 years. Statistically, there is no significant correlation of the duration of diabetes to the musculoskeletal disorders, similar to the finding of Bolstead et al. However, in the study of Matthew et al., there was a significant association between rheumatic musculoskeletal disorders and the duration of diabetes. Only 19 out of the 37 cases had data on BMI, and most of them are obese type 1 and type 2, about 35% of the cases. However, statistically, there is no significant association between the BMI and MSK disorder, contrary to the findings of Bolstead et al., where the BMI was shown to be associated with the pain in the lower back, knee, hip, arm, and the hand. As to glycemic control, only 23 out of the 37 cases had data on HbA1c. About 56.8% of those with MSK complaints have uncontrolled diabetes at hemoglobin A1c of 6.5% and above. Statistically, glycemic control is not significantly associated with MSK disorder, similar with the studies of Bolstead et al. And Cagliaro et al. These are the drug interactions identified in the study and can either increase the risk of myopathy, increase the risk of hypokalemia causing muscle weakness, or increase the risk of tendon rupture. And the most frequently prescribed interaction in the wards are that of atorvastatin and carvedilol. So in this study, the prevalence of musculoskeletal disorders among Filipino patients with diabetes is at almost 39%. Majority of the patients have type 2 diabetes. The knee is the most frequently involved region, and the body mass index as well as the glycemic control are not significantly associated with musculoskeletal disorders. The drug interaction can either increase the risk of myopathy, hypokalemia, or tendon rupture. And lastly, atorvastatin and carvedilol are the most frequently prescribed interacting drugs. Thank you very much.
Good day. I'm Nuri Marie Garcia from the Makati Medical Center Section of Rheumatology, presenting a cross-sectional study on the association of hematologic markers, vitamin D levels, and clinical characteristics with disease activity among Filipinos with axial spondyloarthritis seen in a tertiary hospital. Axial spondyloarthritis is a chronic inflammatory joint disease affecting the sacroiliac joints and the spine. It includes radiographic and non-radiographic. It is characterized by inflammatory back pain, sacroiliitis, excess spinal bone formation, and a high prevalence of HLA-B27. Health instruments are used in evaluating the patient's disease activity and function, such as the Bath Ankylosing Spondylitis Disease Activity Index and the Bath Ankylosing Spondylitis Functional Index. Laboratory parameters such as the ESR and CRP are commonly used to assess disease activity. However, they are not widely available. On the other hand, CBC test is routinely performed in daily practice, and recent studies discover that components of CBC may serve as inflammatory markers. Leukocyte counts and its subtypes have been calculated to evaluate inflammation in various chronic inflammatory diseases. These hematologic markers, such as the neutrophil lymphocyte ratio and the platelet lymphocyte ratio, are observed to correlate with disease activity among patients with axial spondyloarthritis. In another study, AS disease activity was correlated with vitamin D levels, with the hypothesis that vitamin D deficiency is associated with increased disease activity. ESR and CRP are not widely available in all laboratories and are more expensive than usual tests, hence affecting its accessibility to some patients. So this study aimed to investigate the relationship of the degree of disease activity and hematologic markers, as well as vitamin D levels among Filipino patients with radiographic and non-radiographic axial spondyloarthritis. This was a single-center prospective cross-sectional study conducted in the outpatient rheumatology clinics of a tertiary hospital. Data were collected from patients' electronic records and clinic charts. All data gathered were anonymized to ensure confidentiality and analyzed descriptively. Here are the inclusion and exclusion criteria. Patients with debilitating diseases and those with other autoimmune diseases such as rheumatoid arthritis and psoriatic arthritis were excluded. For the results of the study, in the included population, 13 were diagnosed with radiographic axial spondyloarthritis, while 17 were non-radiographic. Overall, the mean age of diagnosis was 45 years old, 27 or 90% were male. In terms of time from diagnosis, 30% of the participants were diagnosed in the past 1 to 3 years, while 26.67% in the past 4 to 6 years, and for at least 10 years. Hypertension and dyslipidemia were the most common comorbidities. In terms of predisposing factors, 7 had a family history of axial spondyloarthritis, and 26 out of 30 were noted to be HLA-B27 positive. Treatment was a combination of NSAIDs, corticosteroids, methotrexate, and biologic therapy. All 30 patients were included in determining the relationship of the hematologic markers, ESR, CRP, vitamin D3 levels to the disease activity scores. Vitamin D3 is strongly and indirectly correlated with BAS-DI. CRP was moderately and directly correlated with BAS-Phe. In assessing factors associated with BAS-DI and BAS-Phe, there was insufficient evidence for most of the clinical parameters, except that for every unit increase in ESR and CRP, BAS-Phe increases by 0.45 to 0.47 times. This cross-sectional study showed that males were more predominant than females at a ratio of 9:1 with regard to axial SpA. HLA-B27 is the most common and important allele for susceptibility in axial SpA. So when a patient is being evaluated for this disease, the presence of HLA-B27 increases the probability. In terms of the biomarkers used to monitor disease activity, one study concluded that BAS-DI score was positively correlated with ESR, CRP, NLR, and had a negative correlation with serum vitamin D levels. This study showed that vitamin D3 is strongly and indirectly correlated with BAS-DI. This was comparable to another study which showed that vitamin D deficiency was associated with increased AS activity as indicated by the BASLI score, ESR, and the CRP. This study showed that for every unit increase in ESR and CRP, BAS-Phi increases. This supports the findings of another study which showed that as ESR increases, BAS-Phi score also increases, deteriorating the functional capacity of the person. This was explained by the disease duration because of the progressive activation of bone remodeling pathways that are likely to affect these biomarkers. This study also showed no statistically significant correlation between the BASLI scores and the ESR, CRP, and hematologic markers. Most studies report that the results about the relationship between the NLR, PLR, and inflammation and disease activity of axial SpA remains to be an elusive matter. For the limitations, one limitation of this study was that it was a single center with a relatively small sample size, which limit generalizability. Therefore, a multi-center prospective study is needed for further verification of the results. Second, a cross-sectional study design limited the results since it is not the best way to evaluate any causal relations. Third, the possible effects of treatment on the hematologic markers were not considered due to incomplete treatment records. For the conclusion, there was insufficient evidence to establish an association of hematologic markers to BASDAI and BAS-Phi. It was found that patients with higher CRP and ESR levels tend to have a higher BAS-Phi score, while patients with lower vitamin D3 levels tend to have a higher BASDAI score. So it is recommended for future studies to have a bigger sample size involving multicenter to more accurately determine relationships. Thank you.
Good day. This is a case report of a young Filipino male who developed sacroiliitis on a background of HIV and syphilis. The close relationship of infection and rheumatic disease is a well-established fact. However, whether the former triggers the latter or vice versa, or whether a mutualistic relationship does occur or not, are just a few queries needing resolution. Where do we draw the line between mounting a full-scale inflammatory response and minimizing self-destructive antibodies? This case aimed to look into the correlation of HIV, syphilis, and the occurrence of sacroiliitis, and more importantly, to review the utility of disease-modifying drugs for this group of patients. A 20-year-old Filipino male single consulted because of chronic low back pain of 1 year duration. He described it as pain on his buttocks, more prominent on the left side, relieved by movement and unrecalled pain medications. He also took steroids and underwent rehabilitation therapy as advised by his previous doctor. He claims to feel some improvement initially but later reported worsening of symptoms. Upon consult with another doctor, there was note of progression of symptoms and signs. Aside from progressive pain, he disclosed limitation of movement of the left hip joint, pallor and palmar and plantar rashes. Here we see flat annular erythematous non-painful non-pruritic macular palmar and plantar rashes. Workup revealed sacroiliitis prominent on the left and bilateral inguinal lymphadenopathies on pelvic MRI, anemia and thrombocytosis, markedly elevated ESR, CRP, and ASO titer, negative rheumatoid factor, and non-reactive screening tests for hepatitis and tuberculosis. The patient was confirmed positive for HIV and syphilis. Pelvic MRI shows narrowing of bilateral sacroiliac joints more in the left, with irregular joint end plates suggestive of sacroiliitis. He was initially given celecoxib 200 mg per capsule twice a day and low-dose methotrexate for joint pains. Penicillin injections for syphilis were also given. Following a confirmatory test for HIV, he was then referred to a treatment hub and methotrexate was temporarily withheld. The patient and family were fully apprised of overall problems, as well as the treatment plans for this patient. He is carefully monitored at the present, and the possibility of anti-rheumatic drugs for the sacroiliitis is still in place, pending infectious clearance. This case describes rheumatic disease as a presenting symptom of an underlying condition. It illustrates the strong relationship between these two diseases, specifically the articular syndromes described in association with HIV, which include HIV-associated arthropathy and seronegative spondyloarthropathies. A high index of suspicion must be kept in mind for appropriate and timely diagnosis. Management options and monitoring of disease activity remains a challenge. HIV/AIDS is a global pandemic, a chronic manageable disease that is markedly affected by multitudes of unmet needs in treatment, socioeconomic, and legal issues. As complicated as it may seem to be, all persons with HIV/AIDS are entitled to adequate and timely support without discrimination, treatment and care with compassion and respect. Let us all help each other to be aware. Thank you.
Good day. Presenting to you a rare clinical case report entitled Pseudomegs or T-Jalma syndrome, an initial presentation in a young female with systemic lupus erythematosus. A 26-year-old female Filipino Roman Catholic and a resident of Santo Tomas, Davao del Norte, who came in due to abdominal distension. Symptoms started 11 months prior to admission when she had onset of low-grade undocumented intermittent fever usually noted in afternoon associated with nausea and epigastric pain. She self-medicated with paracetamol, which offered temporary relief. 10 months prior to admission, there were persistence of symptoms now associated with weight loss, chills, gradual abdominal enlargement, and amenorrhea. 2 separate pregnancy tests taken were negative. 6 months prior to admission, she sought consultation in a local health center due to amenorrhea and enlarging abdomen. Whole abdomen ultrasound was done, but unremarkable. 5 months prior to admission, she had onset of rashes, consulted another physician, but no medications were given. 2 months prior to admission, she was eventually admitted at local district hospital due to persistence of previous symptoms now associated with vaginal spotting, alopecia, vertic chest pain, and shortness of breath. Subsequently, COVID-19 RT-PCR swab test was done, which revealed positive. Managed accordingly, discharge improved after 14 days. However, after 3 days, she opted to be admitted at our institution due to progression of her conditions. At the ER, she was tachycardic and tachypnic. Pertinent physical findings revealed pale palpebral conjunctiva, skin pallor with malar rash. Cardiopulmonary examinations revealed tachycardia and decreased breath sounds, and decreased tactile firmitosis in right basal area with occasional coarse rash on basal areas. Abdominal distension with abdominal girth of 35 centimeters. Shifting dullness and bipedal edema were also noted. The rest of physical findings were normal. She was managed a case of systemic lupus erythematosus. Based on sleep criteria, laboratories taken revealed elevated ANA, anti-dsDNA, hypocomplementemia, elevated ESR-CRP, positive indirect and direct Coombs, normocytic normochromic anemia, and albuminuria, with Selena's letter indicates high SLE activity. Initial workup with whole abdomen ultrasound showed minimal ascites and suspicious pelvic mass. Thus, further imaging with CT scan showed pertinent ascites with minimal bilateral pleural effusion. Colonoscopy was also done, which revealed nonspecific colitis, mixed hemorrhoids. Furthermore, CA125 was also noted to be elevated. Subsequently, she was also referred to OB/GYN service for evaluation, and TVS showed normal uterus and ovaries with ascites. However, CA125 is still elevated. Diagnostic and therapeutic paracentesis was done, but revealed negative TB and malignancy, with serum albumin ascites gradient is 1 gram per deciliter, which points out to a non-portal hypertension cause. With a serum albumin ascites gradient of 1 gram per deciliter, these are the possible differential diagnosis. This is suggestive of non-portal hypertensive ascites as shown in the algorithm. Based on the patient's laboratory results, which is highly suggestive of SLE, along with ascites and pleural effusion, the following were considered: MEGS, pseudomegs, and pseudomegs or T-Jalma syndrome. We rule out MEGS since it's associated with benign ovarian tumor with ascites, pleural effusion, and high CA125. OB/GYN service rule out any forms of primary fibroid, pecoma, or Bremer's tumor for this patient. On the other hand, pseudomegs is also another close differential, which is characterized by ascites, pleural effusion, and high CA125, which is associated with malignancy. However, malignancy was ruled out in our case. Our case is a patient with pseudomegs syndrome or T-Jalma syndrome, which is a clinical syndrome characterized by triad of ascites, pleural effusion, elevated CA125 in an SLE patient in the absence of benign or malignant ovarian tumor, which are all present in our patient. The patient was discharged with a final diagnosis of pseudomegs syndrome or T-Jalma syndrome, systemic lupus erythematosus, and high disease activity. Lupus ascites pleural effusion elevated CA125 was first described by Tejalma et al. In 2005. Smith et al. Later coined the term pseudomex. Through extensive literature search, we only found 18 cases reported worldwide. No published cases in the Philippines yet. For the pathogenesis, our patients may or may not have genetic factors that may have brought abnormal immune response. Interactions between genes, environment, epigenetic changes causes production with an effective regulatory network that explains inflammation theory. Pathogenic autoantibodies would form antigen-antibody complexes deposited in the skin, manifesting as malar rash in the joints causing arthritis, in the lungs resulting to pleural effusion, in the abdomen causing ascites. Due to upregulation of pro-inflammatory cytokines, abnormal immune response causes uncontrolled inflammation would ensue, causing an upregulation of pro-inflammatory cytokines. The elevated CA125 seen in the pseudomegs can also be explained by inflammation theory. Published journals have also noted a correlation between CA125 and the amount of ascites, an independent marker for ascites in SLE, that were initially high levels, then gradually declining and normalizing. With CA125 levels trending to normal range, with improvement of ascites, CA125 may therefore be an independent marker for ascites in SLE. In our case, there were initially high levels of this marker, then gradually declining and normalizing. Since she had high SLE activity with selenous score of 12, hydrocortisone 1 mkd, hydroxychloroquine 5 mkd, and calcium plus vitamin D supplements were added. We still did not consider giving pulse therapy and additional immunosuppressants at this time, since we noted clinical improvement with this regimen. Due to the paucity of data, there are yet no clinical practice guidelines in the management of pseudomegs. Resolution of symptoms are coupled with disease severity and treatment for lupus. After 1 month, with repeat transvaginal ultrasound, there was still no ovarian mass seen with decrease in the levels of CA125. Her ascites also gradually resolved. Medications were adjusted accordingly. In conclusion, pseudomegs associated with SLE is a rare manifestation which needs thorough investigation, multidisciplinary approach, and prompt management. CA125 should alert us about underlying malignant condition, but this can also be present among those with evident tumors. This rare clinical entity is still new in medical literature. Thus, a physician must have high index of clinical suspicion when ruling out other disease entities. From Davao Regional Medical Center, I am Dr. Chad Kevin Fernandez, together with my co-author, Dr. John Elmer Clisadio. Thank you for listening and have a safe stay at Baguio City.
Good morning, PRA. Good morning to our dear mentors. I am Dr. Elaine Tan, a first-year fellow of rheumatology at the St. Luke's Medical Center. Together with my co-fellow, Dr. Rika Kizia King, and our consultant rheumatologist, Dr. Melissa Aquino Villamin, would like to share our case today. It's entitled Ankylosing Spondylitis, complicated by AIDS, pancreatic tuberculosis, cryptococcal meningitis, and immunoglobulin A nephropathy in a young Filipino male. Now, why this case? Well, in rheumatology, we are in the unprecedented era of biologic therapies for AS. And in the realm of infectious diseases, highly active antiretroviral therapy for AIDS is available. Taken together, however, brings forth certain dilemma. After all, there is paucity of data among patients with coexistence of these two diseases. And do allow me to highlight that. Our patient is a 38-year-old male, Filipino, a known immunocompromised host, secondary to acquired immunodeficiency syndrome since 2010. His initial CD4 count was low at 22, but he is maintained on HAART. In the past, he had a series of multiple opportunistic infections, namely pancreatic TB, treated with anti-cox regimen and resolved. Cryptococcal meningitis, treated with fluconazole, and pericardial effusion secondary to HIV. But in the interim, our patient was doing well. In fact, he even had regular and consistent HIV monitoring. His CD4 count has gone up to 335. His HIV viral load was persistently undetectable. And this was in 2019. In 2020, however, he presented with low back pain. It was worse in the morning and occurred after periods of inactivity. The persistence of symptoms for a year prompted rheumatology consult. On physical exam, there were no skin lesions. There was no uveitis, enthesitis, or dactylitis. He, however, had limited range of motion, specifically of the lumbar spine. His flexion was limited to up to 110 degrees. We proceeded with workup. PCBC, liver enzymes, and inflammatory markers were all within range. His HLA-B27 was negative. Lumbosacral X-ray showed a straightened lumbar spine. However, we proceeded with the lumbosacral MRI, which showed a bilateral sacroiliitis. So during this time, we have a working diagnosis of a non-radiographic axial spondyloarthritis. However, our patient also had some complications. In the same MRI, mild compression deformity at the T8 was noted. When we checked his renal parameters, creatinine clearance was reduced. He also had hypokalemia, and urinalysis revealed glucosuria in the absence of frank hyperglycemia and diabetes. Hematuria and proteinuria was likewise noted. We initially performed a kidney ultrasound which only showed a diffuse non-specific bilateral renal parenchymal disease. Hence, when we discussed with the nephrologist Revis, we decided to pursue the renal biopsy, which showed IgA nephropathy. At this point, let us list down the problems that our patient has. Firstly, he is an immunocompromised host. Second, he has a newly diagnosed ankylosing spondylitis. Moreover, he has osteoporosis and IgA nephropathy. Faced with these problems, we have a limited treatment armamentarium that we can utilize. For one, NSAIDs may worsen the pre-existing renal disease. In addition, it only offers partial relief of pain. TNF inhibitors may reactivate his previous opportunistic infections. Hence, we decided to try corticosteroids. Because for AS, it may improve the pain and swelling. For the IgA nephropathy, it may confer renoprotective effects. And true enough, we performed it. He underwent 3 days of methylprednisolone pulse therapy. Let's now see the outcome. Firstly, for his IgA nephropathy, although there was persistent glucosuria and hypokalemia, the patient had, all in all, an improved renal function. For his AIDS, he had persistent undetectable viral load. And finally, for his AS, he had improved pain control, and a repeat lumbosacral MRI showed resolution of the bilateral sacroiliitis. With this case report, I'd like to highlight the pressing need for a treatment armamentarium that is safe and effective for these patients. Again, due to the paucity of data, set treatment guidelines for coexistent disease have yet to be established. Here, we illustrated a case wherein pulse steroids were seen to be safe and effective. But I cannot overemphasize this. The limited treatment armamentarium is a pressing problem, and we hope to highlight that in this forum. Thank you very much, dear doctors, and have a good morning. A pleasant morning, PRA, especially to our dear mentors. I am Dr. Elaine Tan, a first-year rheumatology fellow at the St. Luke's Medical Center. Together with our rheumatology consultant, Dr. Eileen Agbanlog Di Matulak, it is our greatest privilege to share this case, that of hemophagocytic lymphohistiocytosis, presenting as B symptoms in a young female with SLE in remission. Now, some say that rheumatology is the final frontier of internal medicine. The rarities, the 1 in a million diagnosis, they thrill us and they excite us. But just how rare is rare? Well, amongst all cases of SLE and HLH, the incidence is that of about 0.9 to 4.6%. And so, without further ado, let me present our patient. She is a 33-year-old female, Filipino, and is a diagnosed case of SLE since 2014. She is compliant with her maintenance medications. Her comorbids include a non-functioning prolactinoma and hypothyroidism that is clinically and biochemically euthyroid. Likewise, she has biopsy-proven lupus hepatitis that is currently in remission. And in the interim, our patient was well, until she presented with 20-day history of fever, of Fell-Epstein pattern, cyclic chills, drenching night sweats, and unintentional weight loss. These constitute B symptoms. At the ER, she was tachycardic, highly febrile, pale-looking, with multiple palpable lymphadenopathies. She had no active synovitis and no active dermatosis. Initial ancillaries at the ER revealed mild anemia and thrombocytopenia. Her urinalysis and chest X-ray was unremarkable, and she was given supportive management. Nevertheless, her high-grade fever, chills, and drenching night sweats persisted. Serial CBC monitoring showed decreasing trends, and overall, it was consistent with a pancytopenic picture. From rheumatology standpoint, we checked for disease activity of her SLE. We requested for ESR and CRP, which were within range. Likewise, her complement levels C3 and C4 were normal. She had persistence of symptoms, but from a rheumatology standpoint, her SLE is not in flare and it has a disease activity index of 3. The infectious services did an extensive workup and they ruled out a bacterial, viral, fungal, and mycobacterial infection. During this time, she was persistently febrile and we proceeded with imaging. Her neck CT and chest CT both showed enlarged lymph nodes. Likewise, we proceeded with a whole abdominal CT showing an enlarged spleen, a normal-sized liver, note of multiple enlarged lymphadenopathies, and what we found was an incidentaloma, a right suprarenal mass that was suspicious for either a malignancy or an extrapulmonary tuberculosis. During this time, the team decided to go for a biopsy. However, the CT-guided biopsy showed inconclusive results, that of soft tissue fragments with marked necrosis. She was persistently febrile and severely neutropenic. Serial monitoring of our inflammatory markers and complement levels were all within range, and her SLE was deemed to be in remission. At this time, we proceeded with a more definitive approach. She underwent adrenalectomy, which revealed a benign mass and adenoma. Likewise, PBPCR was negative. Also during this time, the hematology service performed a bone marrow aspiration biopsy. Here, it showed that there was no acute leukemic blast cell population. However, histopathologic findings were very characteristic. It involved a markedly hypocellular bone marrow with erythrophagocytosis and interstitial histiocytic hyperplasia, leading us to our diagnosis of HLH. Now, we made use of a validated score, the H-score, with 3 components: clinical, biologic, and cytologic. For our patient, she had a total score of 271 points, consistent with a more than 99% probability of hemophagocytic syndrome. Hence, at this point, after arriving at our diagnosis, she underwent treatment with the HLH treatment protocol. She likewise underwent a hematopoietic stem cell transplant with her brother as a donor. And I am very happy to see her outcome. She has no recurrence of fever. She has improved blood counts. Her latest PET scan showed regression of the lymphadenopathies, and her SLE remained and remains to be in remission. Now, as a young rheumatology trainee, I'd like to say that despite its rarity, HLH in the background of SLE, even in remission, may occur. Prompt recognition is warranted to avoid its fatal complications. And with that, I'd like to thank the PRA for giving us this opportunity. Thank you very much po, and have a wonderful morning.
Diffuse alveolar hemorrhage is a life-threatening condition that presents with anemia, hemoptysis, dyspnea, desaturation, and respiratory failure. The occurrence rates of DAH and SLE widely varies from 0 to 90%. Currently, there are no standard guidelines to treat this condition. However, methylprednisolone pulse therapy is recommended for life-threatening lupus disease activity. For non-responders to first-line treatment, therapeutic plasma exchange or TPE and rituximab can be used as rescue therapy. TPE is an excorporeal removal of large molecules from the plasma, while rituximab is a specific anti-CD20 antigen B-cell antibody. To the best of my knowledge, locally, this is the first reported successful treatment of DAH in 2 cases of newly diagnosed lupus patients. Naimbag na bigat kada kayo amin. I am Dr. Lori Gail Barcena, and I'll be presenting to you a case series entitled Diffuse Alveolar Hemorrhage in Lupus, a rare, favorable outcome to the therapeutic plasma exchange plus rituximab, a case series. We have 2 cases of young Filipino females. Case 1 presented with 1-month history of progressive bipedal edema with associated oliguria and orthopnea. Physical examination revealed tachycardia, tachypnea, anosarca, and generalized multiple well-defined hyperpigmented circular lesions. Her SLE was diagnosed based on clinical history, PE, and supported by a positive ANA, elevated dsDNA, and low C3. During the course of the admission, she consecutively developed rapid progressive glomerulonephritis,
neuropsychiatric SLE presenting as seizures, and myocarditis. She was treated with the following medications, which showed good response. However, she subsequently developed persistent hemoptysis, anemia, thrombocytopenia, and episodes of desaturation, eventually needing invasive mechanical ventilation. At this time, DAH was being considered. Case 2 presented, on the other hand, with persistent hemoptysis and vaginal bleeding. She is a known case of idiopathic thrombocytopenia for 3 years. PE was unremarkable except for tachycardia, and her SLE was also based on the clinical history, PE, and supported by a positive ANA, elevated dsDNA, and low C3. Her lupus disease activity included severe thrombocytopenia and lupus nephritis. She was initially treated with high-dose steroids with noted partial response. During the course of the disease, there was noted recurrence of hemoptysis and thrombocytopenia. At this time, DAH was also considered. The diagnosis of DAH is based on diffuse pulmonary infiltrates seen on radiography with anemia, desaturation episodes, and hemoptysis. The initial chest X-ray of both cases were compatible with the set findings of DAH. These images show the pre and post rituximab chest X-ray of both patients, where we can see the resolution of the hazy densities. Case 1's bronchoscopy imaging shows the left main stem bronchus covered by blood clots. Bleeding was noted to originate from the left lower lobe segment. Case 2's bronchoscopy imaging shows active bleeding with petechial hemorrhages on all segments of bronchial mucosa. DAH is a life-threatening lupus complication with 0.6 to 5.4 incidence and 86 points mortality rates. In the local setting, a case series of 2 Filipino women with SLE who both manifested with DAH were also published. They were treated with methylprednisolone, cyclophosphamide, and plasmapheresis were planned but was not done. Rituximab was not given either. Both patients mentioned in this study died days after being diagnosed with DAH. Some case series show that 3 out of 22 patients who received rituximab survived, but in another case series of 140 SLE patients, 3 out of 8 patients who received rituximab died. On the other hand, one study analyzed 66 patients who were treated with plasmapheresis, 20 of which had DAH, where 55% showed improvement. According to the Mexican College of Rheumatology, glucocorticoids like methylprednisolone succinate are the cornerstone of treatment for SLE. Both patients were given this treatment, however, case 2 did not show any response. TPE is considered as a second-line therapy for SLE, according to the American Society for Apheresis guideline, since it was shown to be effective in reducing the ANA, anti-dsDNA, restoration of normal complement level, and reducing the antiphospholipid antibodies. On the other hand, rituximab is recommended for renal, neuropsychiatric, and other life-threatening SLE manifestations which do not adequately respond to the standard of care. Both patients were given rituximab and TPE, and positive responses were noted. Prognosis of SLE patients with DAH is poor, especially those who present with concurrent infections, and as mentioned, has an 86% mortality rate. With all this information at hand, high doses of glucocorticoids remain the cornerstone in treating SLE-associated DAH. However, TPE and rituximab may be used, especially when the condition is refractory to the initial management. Since DAH is one of the most severe forms of pulmonary involvement in SLE, clinicians should be prompt in identifying the earliest signs and symptoms of this condition, and to be able to formulate and provide sound immediate medical strategies, such as use of TPE and rituximab, to prevent further complications and mortality in patients with this condition. Thank you.
Sound check. Well, congratulations to all residents, fellows, and all their mentors. I think everybody deserves a big round of applause for that. Thank you very much. Just an announcement before we move on. Winners for the poster contest as well as Best in Image shall be announced after the last lecture of the day. This is the 29th Philippine Rheumatology Association Annual Meeting, Day 4. For those of you who just joined in, good morning to you. And we now go to the next part of the scientific program, the Lupus Roadshow.